Okay, so good morning. This morning session, we're gonna look at cardiac tumors and masses. Um, so, we commonly encounter mass and tumors in the heart, and it's important for us to identify, what we're dealing with. Some mass or tumor need immediate attention. Others you can wait a little bit longer, but it's important for you to have an idea of what's going on. Um, so most of you guys, or all of you guys, have seen masses and tumors. So this topic should be very relevant. So what we're going to do is we're going to look at what we call benign and malignant tumors. We're also going to look at primary and secondary tumors, and we have to have a clear definition of these different scenarios. So when we talk about a primary tumor, it's a tumor that develop inside the heart. It develop inside the heart. That's a primary tumor, as opposed to a secondary tumor where you might have, say, a breast cancer, and then it metastasizes to the heart. So that's a secondary tumor. Okay, and the benign uh, tumor is one that's non-cancerous. Okay, so it's not going to metastasize, it's not going to invade uh, structures, as opposed to a malignant tumor, which is a cancerous tumor. Okay, so you have to have those definition clear. And then there are normal cardiac structures that sometimes mimic pathology. Common one is the eustachian valve. Sometimes you look at the eustachian valve, and it might look like a thrombus, okay, or the papillary muscle. Sometimes it may be a little bit prominent, and you think of it, you may think it's a tumor. And then thrombus. Thrombus, that is blood clot. Blood clot formation inside the heart is can be fairly common, and it's important to make that diagnosis because the treatment is important. Um, you commonly get blood clots in area of the heart where the wall is not moving. Okay, if ejection fraction 20% in the apex of the heart, a lot of time you'll get apical thrombus. You can get the thrombus formation elsewhere if the wall is not moving. And then also patients with atrial fibrillation, because the atrium is not contracting, you can get blood clot formation in the left atrial appendage, and that's a cul-de-sac. And because the atrium is not moving, blood stagnates there, and you commonly get clots. So those are the different tumors and masses that you'll encounter. Okay, so so primary tumors, that are tumors that develop inside the heart, they're fairly rare. They're not very common. The more common scenario is secondary tumors. So you have, say, a breast cancer with metastasized to the heart. Those are more common. So let's look at some of the primary tumors. Okay, that is tumors or masses that develop inside the heart. One of the most common ones is the myxoma. The myxoma. And so the myxoma is the most common primary tumor of the heart. You have to know this. The myxoma is the most common primary tumor of the heart. Most commonly it's located in the left atrium, but it can occur elsewhere. But the most common location is in the left atrium. It tends to be pedunculated and attached to the interatrial septum by a stalk. So you'll see a stalk attaching this tumor to the atrial septum. and it's usually in the vicinity, close to where the fossa ovalis is located. Okay, so all right. You can have blood clot formation on top of these myxomas, or sometimes the myxoma itself can embolize. When we say embolize, we mean it breaks off and travel to a distant location, and it can travel to the brain, and you can get a stroke. Okay? Sometimes these myxomas are not readily identified. Take a little time before someone is diagnosed with it, and in the meantime they'll lose weight, and we say that they're cachexic, a significant weight loss, and they look cachexic. Or it can block the if you have a left atrial myxoma, it can block the mitral valve, so there's no blood going to flow from the left atrium into the left ventricle in diastole, so the patient will pass out. Similarly, we had a case that you guys are familiar with where the tumor was actually at the left ventricular flow tract, and that tumor blocks the left ventricular flow tract. Same thing. If no blood can get out of the heart, the patient is going to pass out. Worst case scenario, the patient can die, because if there's no blood flowing out of the heart, patient dies. So, but syncope, because what will happen is that in diastole, when the mitral valve opens, the myxoma tries to get out of the left atrium, so it blocks the mitral valve in diastole. But in systole, when the mitral valve closes, then it moves away. All right? And of course, again, sudden death. The patient can die. And a lot of time, these myxomas are what we call incidental finding. The patient come to the lab for some other reason, and you find that they have a left atrium, they have a myxoma, not necessarily in the left atrium. It can be anywhere. Okay? Or the patient may have a stroke, come to the echo lab, and you find that they have a myxoma. All right, so on the M mode, the myxoma looks like this, and this is classic. They bring this in all exams. If on top you have the parasternal long axis view, your left atrium is right here. Let's look at this a little bit better. So your left atrium is right there. If you look closely, you see that there's something in the left atrium. Okay, your cursor courses right here, and these are the structures. It crosses the mitral valve, your cursor. So when you look down below, you have the chest wall. Below the chest wall, you have the RV wall, and then the RV cavity, then the septum. Below the septum, you have the LV cavity with the mitral valve, and your ECGs on the bottom. In diastole, when the mitral valve opens, you can see this mass. You can see this mass, this tumor, this myxoma. So in diastole, when the mitral valve opens. In systole, when the mitral valve closes, you don't see anything. But in diastole, mitral valve open, and you see the myxoma. So this is sort of classic. And when you see that, you have to make your diagnosis. Okay? All right. All right. Again, if you have if you have a parasternal, apical four-chamber view, you can see the myxoma clearly. So it is a mass or a tumor which is attached to the interatrial septum at the vicinity of the fossa ovalis, and it's attached via a stalk. Okay, so it's a mass or a tumor attached to the interatrial septum at the vicinity of the fossa ovalis. And when you see one of these tumors, it look classic. On the echo, it looks very distinctive. And then if you were to look at the pathology, if you see one, it looks like a bag of grapes. It looks like a bag of grapes. So it has a very distinctive feature. The next tumor that we're going to look at is called a fibroma. Okay, it's another benign tumor. So again, remember, a benign tumor is a non-cancerous tumor. Okay. So the next one is fibroma, which is rare. It's a benign tumor, rare. Occur mainly in children. So you have to sort of remember this, because if you do a child and you see a tumor, most commonly in the vicinity of the interventricular septum or the left ventricular free wall, it's probably a fibroma. Okay? Fibroma. So when we talk about fibroma, it's a fibrous tissue tumor. So it's a fibrous tissue tumor. Occurs mainly in children, and it's the most common location is in the interventricular septum and the left ventricular free wall. So that's what we call the lateral wall then. Okay? Fibroma. And then the next tumor we're going to look at is called a rhabdomyoma. When we talk about rhabdo, rhabdo means skeletal muscle. So, and skeletal muscle is the muscle you have in your thigh, the muscle you have in your leg, the muscle you have in your arm, the muscle you have in your chest. Those are what we call skeletal muscle. The medical term for it is rhabdo. And when you talk about myoma, well, myoma is muscle. Sorry, muscle tumor. So myo means muscle. Myo. So when we say rhabdomyo, it means skeletal muscle. Oma means a tumor. So rhabdomyoma is the next tumor. Okay. So this is most common. It's the most common primary pediatric tumor of the heart. Again, it occurs in kids, but it is the most common primary pediatric tumor. Okay, and another important association, it occurs in kids with what we call tuberous sclerosis. So you need to go and look what tuberous sclerosis looks like. These kids have multiple tumors on their skin. Sometimes they have mild mental impairment. Okay, but rhabdomyoma, which is the most common primary tumor of the kids with tumors in the heart, and it is associated with tuberous sclerosis. Okay, these tumors sometimes undergo spontaneous regression; they just disappear. Okay, the most common location is in the right ventricle, in the right ventricle or the right ventricle outflow tract. Okay, the rhabdomyoma. Now we move on to some other tumor, and one is what we call papillary fibroelastoma. This is fairly common. This is the third most common primary tumor of the heart. And this tumor, papillary fibroelastoma, usually is located on the aortic valve, the most common location. But you can also find it in the mitral, tricuspid, and pulmonary valve. But the most common location for it is the aortic valve. And it may cause embolic phenomenon. So you may have blood clots forming on top of this tumor, and it can break off. They're usually relatively small, but they can get large. They can get large. Okay, so you'll see the tumor, you'll see the mass on the aortic valve, which is the most common location, and it's called papillary fibroelastoma. So, this is a transesophageal echo, and you see this tumor on the aortic valve. So This probably bring back memory to some of you guys. Say, oh yeah, this is a papillary fibroblastoma. Okay, so you need to go over your lectures so that when you see something, you have an appreciation of what it might be. So it's a benign tumor. The most common location is the aortic valve. Okay, papillary fibroblastoma. You may get embolization from it. So again, papillary fibroblastoma on the aortic valve. This is a transesophageal echo. Okay, if you remember, this is going to be this is your atrial septum, so this is going to be your non-coronary cusp. Okay, your right will be right here, and this would be the left. Okay, so this is a papillary fibroblastoma on the left. Okay, it's on the left. It's on the left. Okay, so that is what it looks like, and you should be able to make that diagnosis. Okay. Okay. So this is one on the pulmonary valve. So it's a papillary fibroblastoma on the pulmonary valve. Okay. This is a transesophageal echo, and your atrial septum is right there. It's your right atrium, tricuspid valve, or right ventricle flow tract. Pulmonary valve is right there. So it's on your pulmonary valve. Okay. All right. So those are the benign tumors, primary benign tumors of the heart. You have to know them. So you have to go over it. If they ask you, because in the question, if they ask you, they show you a mass, say in the the ventricular septum or the ventricle, and they talk about a kid, and they show you a picture and there's multiple tumor in the patient and the kid's skin, or if they talk about tuberous sclerosis, it's rhabdomyoma. Okay, once they talk about tuberous sclerosis, it's rhabdomyoma. So association like that is important. They're going to give you common tumors though, so they'll definitely give you the myxoma. All right. So when we say malignant tumor, these are cancerous lesions, and you can have primary cancer that forms inside the heart. So angiosarcoma, when we say angio, we mean blood vessels. So it's a cancer of the blood vessel in the heart. And then again, rhabdomyosarcoma. Rhabdo means skeletal muscle. Rhabdo means skeletal. Myo means muscle. So it's a skeletal muscle-like cancer. So one of the questions you can ask is, how come you have a skeletal muscle cancer in the heart? Yes, it can occur. It can occur. Or you can have what we call myxosarcoma. Myxosarcoma. So a myxoma, which is cancerous. Myxoma is a benign lesion. Or osteosarcoma. Osteo means bone. So you can get a bone cancer inside the heart, yes. Or fibrosarcoma, so a fibrous tissue, which is cancerous. Or synovial sarcoma. When we talk about synovial, we talk about joints. So when you talk about synovial joints, so you can get a joint like cancer inside the heart. And the reason for that is, these cancer can take any form. They can go back to their developmental stage and you can get cancer of anything. All right. Or you can get a secondary cancer. So that is, you get a cancer anywhere in the body which metastasizes, travels to the heart. So you can have a lung cancer metastasize into the heart, breast, kidney, liver, and then lymphoma, which is a cancer of the white blood cells. Okay, Okay, melanoma of the skin, osteogenic sarcoma, so a bone cancer with metastasized to the heart. All right, so those are some of the cancers. Now, what about masses? So you commonly see some mass inside the heart, and you wonder what it is. All right, so in the right atrium, the eustachian valve is commonly mistaken for a tumor. Remember that the eustachian valve, which is a remnant of the valve of the inferior vena cava, it usually lies at the junction of the inferior vena cava and the right atrium. In fetal life, that's when the baby is being developed, it serves the purpose of directing oxygenated blood from the right atrium into the left ventricle. So that is what it does in the developing baby. Because remember, the lungs are not fully formed, so there is no oxygenated blood traveling from the pulmonary veins into the left atrium in the baby. None of that. Remember, the baby gets its blood from the placenta. Okay? That is why placenta function is so important in the developing baby, because that's where the oxygenated blood comes from. And then it goes to the right atrium. So you have to redirect it from the right atrium into the left atrium. And that this eustachian valve, that's what it does. To see the eustachian valve, you can see it in the apical four-chamber view or the subcostal view when you do your transthoracic echo. And then if you're going to do your transesophageal echo, the bicaval view will show it to you. So your apical four-chamber view, left side is over here, left ventricle, mitral valve, left atrium, ventricular septum, atrial septum, right atrium, right ventricle. You commonly see these structures in the right atrium. You know, remember the inferior vena cava is about right here, and it drains into the right atrium. And you commonly see this structure. This is usually what the eustachian valve looks like. Okay, well, that's what it looks like. So you can also see it in the subcostal view. All right, so eustachian valve. Other things you can see in the right atrium, in addition to the eustachian valve, you can see pacemaker lead, you can see central line catheter, thrombus, blood clots, and vegetation. You may see vegetation on the tricuspid valve or vegetation on pacemaker leads. Okay, so this is apical four-chamber view, right side, left side, and this structure right here is the pacemaker lead. Okay, it's in the right ventricle, and if you follow it all the way, you see it into the right atrium as well. Okay, so this is actually a vegetation on the tricuspid valve, a huge vegetation on the tricuspid valve. Okay, left side, right side. Remember, vegetation is an infected mass, usually on the valves. So when we look at the left atrium, you can patients with atrial fibrillation, as mentioned before, because the atrium is not contracting, blood stagnates, and you have more stagnation in the left atrial appendage, and you get blood clot formation there. It's important to recognize this because it's very common for these blood clots in the left atrial appendage to break off and travel to the patient brain, and they get a stroke. So that is why patients with atrial fibrillation, we recommend blood thinners, anticoagulants, because they'll get thrombus, blood clots in the left atrial appendage. Okay. It's more common, well, we see it in atrial fibrillation, but if the patient have mitral stenosis, it's extremely common, very, very common if they have mitral stenosis and atrial fibrillation. Okay, and if you remember, to see the left atrial appendage, you're gonna need to get your transesophageal echo. You can't see the left atrial appendage with transthoracic echo. You need your transesophageal echo in order to see the left atrial appendage. So that's important. So if you have an extensive left atrial thrombus, you can see it. But again, if the blood clot is in the left atrial appendage, you cannot see it. You cannot see it with your transthoracic echo. Okay. The lipomatous hypertrophy of the atrial septum. This is a very common exam question. They love this for whatever reason, and it's sort of classic. So lipomatous hypertrophy of the atrial septum. The atrial septum has a sort of dumbbell appearance. It has a dumbbell appearance with sparing of the fossa ovalis, and it gives the atrial septum a thickness of about 15 millimeters or greater. So if you see the atrial septum thickening 15 millimeters or greater, with sparing of the fossa ovalis, having a dumbbell appearance, is probably what we call a lipomatous hypertrophy of the atrial septum. When you say lipo means fat, lipo means fat. So it's a fatty tumor, okay, causing hypertrophy. Again, is a swelling, thickening. So it's a lipomatous thickening of the atrial septum. And it looks like this. So this is a transesophageal echo, and your septum, your atrial septum, is actually right here. This is the fossa ovalis. It's spared. Fossa ovalis is spared, and you get this thickening above and below the fossa ovalis. So all of this is the septum. The thickness is usually greater than 15 millimeters, and that's why it has this dumbbell appearance. Dumbbell appearance of the atrial septum. Okay, it has this bright appearance. Fossa ovalis is spared. This is classic lipomatous hypertrophy of the atrial septum. So lipo means fat. So it's a fatty tumor which causes thickening of the atrial septum. All right, so we'll move now to the left ventricle. The left ventricle, you're commonly going to have thrombus in the left atrial, in the apex, in the LV apex, especially with a very low ejection fraction. So if the patient has a low ejection fraction, 20%, or if they have a heart attack, infarct, which involve the apex, and the apex is not moving, you have to look for these clots. So it's a blood clot in the left ventricle, most commonly in the apex. It usually complicates patients with heart attack, especially the heart attack, myocardial infarction, which involve the apex of the left ventricle. Okay, and it usually complicates between 5 and 15% of these individuals. And then if the patient has a dilated cardiomyopathy, ejection fraction, say 20% or around in that region, the apex is not moving at all, so the blood clots. So you get left atrial, you get LV apex thrombus. Or the clot can form on the whatever wall. Once the wall is not moving, it's fair game for clot formation. These clot may break off and embolize, travel, so the patient may get a stroke, or they travel to the intestines, and they may get intestinal infarcts. The intestine, block the blood vessel going to the intestines, and the intestine dies. Okay? You have to use contrast to confirm this diagnosis. So this is one of the situations where you should use contrast. microbubble contrast. Okay, so this is a case, apical 4-chamber view. You see something right there, the ejection fraction may be, 20%. And then when you look here, so this is a case that you should use your color flow. Use your color flow, because if this is thrombus, the color cannot and will not go into the clot. Or if you give contrast, microbubble contrast, it's not going to go into the clot, because the clot is usually a solid structure. So, okay. Another very important and exam type scenario is your hypereosinophilic cardiomyopathy. Hypereosinophilic cardiomyopathy. So this is a scenario where you get blood clots in the left ventricular apex. You get blood clot in the left ventricular apex. However, as opposed to a regular blood clot in the left ventricular apex, this ejection fraction is normal. The ejection fraction is normal, but you have this apical blood clot, apical thrombus. When you do a blood test and you look at the eosinophil count, eosinophil is a form of white blood cell. So, when you do blood tests, you look at what we call CBC, complete blood count. And the complete blood count is going to give you the white blood cells and to also give you the hemoglobin, the red blood cells as well. When you break down, when you look at, because white blood cell is you have neutrophils, lymphocytes, you have different types of white blood cells. And this eosinophil is a specific type of white blood cell. And the level will be elevated more than 1500 per ml. This is classic. Once you see this, it's hypereosinophilic cardiomyopathy. So on the exam, they're going to give you this. They're going to let you know that the ejection fraction is normal. They're going to show you a thrombus in the left ventricular apex, and you have to know it's hypereosinophilic cardiomyopathy. And sometimes they'll have pericardial effusion. The clot can break off, giving rise to thromboembolic disease. And you also have to use contrast to make the diagnosis. So again, you see the blood clot in the apex. Okay, the difference between this and your regular blood clot is that the ejection fraction here is going to be normal. The ejection fraction is going to be normal. Okay, and if you treat these individuals, you treat the underlying, usually some underlying infection. Once you treat them appropriately, it disappears. Okay, whereas if the patient has a dilated cardiomyopathy, or if they have a heart attack, which involves the left ventricular apex, you have to give them blood thinners for that to disappear. Okay, so that concludes our session, cardiac tumors and massive